Hello, this FERNE presentation addresses the issue of treating emergency department patients with dizziness and vertigo with the goal of diagnosing and treating serious central etiologies. Today, we're going to talk about vertigo patient bedside physical exam. My name is Edward Sloan. I'm an emergency physician in Chicago. I serve as the FERNE president and board chair. I have no financial conflicts. Please go to our FERNE.org website or our YouTube channel for more information on the care of these and all patients with neurological emergencies. So we will specifically address peripheral versus central findings on the vertigo patient bedside physical exam. This comes from the good monograph written by Dr. Jonathan Edlow, 2019, The Timing and Triggers Approach to the Patient with Acute Dizziness, published by EB Medicine. So in this table, we will address the 5 important physical exam findings that need to be addressed and determined for all dizzy vertigo patients. These include abnormal nystagmus, test of skew, the head impulse test, the targeted neurological examination, and gait and truncal ataxia seen here in yellow. So what are the peripheral findings? What are those findings that suggest a peripheral etiology? So if we have dominantly horizontal, direction-fixed beating away from the affected side nystagmus, that is relatively normal in a vestibular system that is affected on one side. Regarding test of skew, there's normal vertical eye alignment and no corrective vertical movement when you cover and uncover one eye. In other words, no skew deviation. The head impulse test will have one side that is abnormal. The eyes will move abnormally and come back to the center. This is called the correcting fixation saccade that suggests a unilateral abnormality to one of the vestibular systems. On neurological exam, there are no cranial nerve, brainstem, or cerebellar signs, and there is no evidence of ataxic gait or truncal ataxia. Now, what are the central signs that would suggest a central etiology to the dizziness here in red? So if the nystagmus is torsional, round, vertical, or it goes in both directions, it's fast in one direction, fast in the other direction, bidirectional nystagmus is of more concern. The test of skew, when you uncover and uncover one eye, if the eyes vertically are not lined up, if the pupils don't align and there's a correction that occurs following uncovering one of the eyes, this is vertical skew. This suggests a central etiology. The head impulse test would be normal. That is, there's no corrective saccade on either side because both vestibular systems work. On neuro exam, if there's limb ataxia, dysarthria, diplopia, ptosis, anisocoria, facial sensory loss to pain and temperature, or unilateral decreased hearing, those are signs that suggest a central etiology for the vertigo. And last, if the patient is unable to walk without a wide-based gait, or if they have to hold on to the bed rails because they have truncal ataxia, this also would suggest a central etiology. So we know now that there are specific findings, 5 in fact, that can help to determine whether or not the cause of the vertigo is likely peripheral or central. If you know these 5 signs and what are suggestive of a central etiology, when they are all absent, you can send the patient home, knowing that it's not likely a central etiology. Conversely, if any one of the 5 are positive, you then can say the patient may have a central etiology and investigate further and consider hospital admission. Any comments or questions on this content or any content from FERNE, get a hold of us at ferne.org at gmail.com. Thank you and have a good day.